The clinical manifestations of chronic kidney failure. Virtually every body system is affected in end-stage kidney disease. Patients exhibit a number of signs and symptoms, and they depend on the degree of renal impairment, other underlying conditions, and age. Early clinical manifestations of CKD causes nausea, apathy, weakness, and fatigue, and declining urine output leading to oliguria. Later, vomiting, increasing weakness, lethargy, and confusion may occur. Peripheral neuropathy may be present, which can cause severe pain and discomfort. Some also complain of restless leg syndrome and burning feet due to accumulation of uremic waste. Various degrees of paresthesia and sensory loss is reported. Personality changes such as anxiety, irritability, hallucinations, seizures, and coma is possible. Increasing levels of serum creatinine and BUN and decreasing GFR is seen. Sodium and water retention increases the risk for edema, heart failure, and hypertension. There is alteration in fluid and electrolyte balance leading to sodium and water retention, increased potassium, magnesium, phosphorus, and decreased calcium. Phosphorus and calcium have a reciprocal relationship in the body. With increasing phosphate levels, the calcium level decreases. Decreased calcium level causes increased secretion of parathormone from the parathyroid gland. Parathormone causes the calcium to leave the bones, resulting in bone changes and calcification of major blood vessels. Moreover, the production of the active metabolite of vitamin D by the kidneys decreases, which plays an important role in calcium metabolism. Bone fractures, bone pain, foot drop, muscle cramps, muscle weakness, loss of muscle strength, and renal osteodystrophy is also seen. Metabolic acidosis occurs because of impaired hydrogen ion excretion and inability to reabsorb bicarbonates. Respirations may change to Kussmaul pattern with declining level of consciousness due to metabolic acidosis. Kussmaul is abnormal deep and rapid breaths that occurs as an involuntary response to severe acidosis. Inadequate production of erythropoietin by the kidneys leads to chronic anemia and subsequent fatigue and shortness of breath. Skin becomes pale, dry, and flaky with gray-bronze hue due to the accumulation of metabolic waste causing pruritus, itching, and uremic frost, which is crystallized deposits of urea on the skin. Basically, the skin takes over the excretory function of the kidneys to some extent. Uremic toxins causes platelet dysfunction that results in thrombocytopenia, and purpura may be seen. A fixed urine specific gravity at 1.010, that is equivalent to the specific gravity of plasma, is seen. Proteinuria, hematuria, and CAS are also seen in the UA or urinalysis. GI disturbances includes anorexia, nausea, vomiting, GI bleed, diarrhea or constipation, hiccups, metallic taste, mouth ulcers, bleeding and halitosis due to ammonia breath, also known as uremic factor, is also frequently seen. Complications of CKD. The first is fluid volume overload. Fluid volume overload is due to the inability of the kidneys to produce urine and maintain the fluid balance. Anemia from the decreased erythropoietin production, decreased RBC lifespan, bleeding in the GI tract from irritating toxins and ulcer formation, and blood loss during hemodialysis. Bone disease from metastatic and vascular calcifications due to retention of phosphorus, low serum calcium levels, abnormal vitamin D metabolism, and elevated aluminum levels. Hyperkalemia is caused due to the decreased excretion, metabolic acidosis, catabolism, and excessive intake of potassium through diets, medications, and fluids. Hypertension is caused due to the sodium and water retention and malfunction of the RAS. Pericarditis, pericardial effusion, and pericardial tamponade is caused due to the retention of uremic waste products and inadequate dialysis. Nursing care. So the first is excess fluid volume. Assess for signs and symptoms of fluid volume excess, daily weights, maintain strict eyes and nose, limit fluid intake, identify potential sources of fluids like IV antibiotics, foods, administering oral medications, etc., and prepare for dialysis. Imbalanced nutrition. Assess factors for altered nutrition intake, weight changes, lab values for electrolytes, iron, proteins, food preferences. Assess for evidence of inadequate proteins like edema, delayed wound healing, and decreased serum albumin levels. Promote intake of high biological value proteins like eggs, dairy products, and meats. Encourage high calorie, low protein, low phosphate, and low potassium snacks in between meals. Alter schedule of medications to avoid giving them immediately before meals. Provide written lists of foods allowed and suggestions for improving taste without use of potassium and sodium. Fluids are usually restricted to the previous day's output plus 500 ml. Protein and fluid restrictions are dependent on whether patient is on dialysis or not. Deficient knowledge. Assess understanding of cause of the kidney disease, relationship of fluid and dietary restrictions to kidney disease, medications, follow-up schedules, and treatment option. Activity intolerance. Assess factors contributing to activity intolerance, like anemia, fluid and electrolyte imbalance, uremia, depression, dialysis. Promote rest in between activities. Risk for low self-esteem. Assess patients' and families' responses to the disease, coping pattern, social support, social services available in the community. Risk for potential complications. Monitor for hyperkalemia, mainly serum potassium levels, muscle weakness, diarrhea, EKG changes, which is tall T waves and wide QRS complex, and palpitations. Monitor for pericarditis, pericardial effusion, pericardial tamponade. So basically you're looking for fever, chest pain, pericardial friction, hypertension, weak or absent peripheral pulses, and altered level of consciousness. Monitor for hypertension, including blood pressure, headache, vision changes, edema, seizures, and signs of fluid overload. Monitor for anemia, including RBC levels, hemoglobin hematocrit. Bleeding precautions are to be maintained. Avoid unnecessary blood draws. Administer erythropoietin as per ordered. Multivitamins, folic acid, and iron-rich food. Bone disease and metastatic calcifications. Administer phosphate binders, calcium supplements, vitamin D supplements, assist with exercise program, and monitor lab for electrolytes. And lastly, monitoring for infections, UTI, catheter or line-related infections. Treatment for hyperkalemia. So this includes stopping all the potassium supplements if prescribed for the patient. IV diuretics can be used if the patient is still producing urine. For example, loop diuretics such as furosemide or Lasix. Sodium polystyrene sulfonate or K-oxalate is used and it works by exchanging the sodium ions for potassium ions in the intestinal tract. This can also be given as orally or as an enema. If it is mixed with sorbitol, it causes diarrhea when giving it PO. Calcium chloride or gluconate is also used in the treatment of hyperkalemia. And the calcium salt stabilizes the cardiac cell wall membrane against depolarization. Sodium bicarb is used when in acidosis, where it helps shift the potassium into the cell. IV dextrose with the insulin is also used as a treatment. So IV D10 or D50 with 10 to 15 units of insulin is given, and it helps to shift the potassium into the cell. Hemodialysis is the largely preferred method in CKD patients, and this helps remove excess electrolytes and fluids from the body. Calcium and phosphate imbalance. Calcium and phosphate have a reciprocal relationship. That is, high calcium, low phosphate levels, and low calcium, high phosphate levels. Phosphate binding agents help prevent a rise in serum phosphate levels by decreasing the absorption of phosphate from the intestinal tract. Phosphate binders are given only with food to help decrease the absorption of the phosphorus from the GI tract and thus gets excreted. Excess phosphorus combines with calcium to form calcium phosphate crystals. Therefore, phosphate binders are administered to bring down the phosphorus levels. Examples of phosphate binders are lanthanum carbonate or phosrenol, sevelamer carbonate or Renagel and Ranvela, and calcium carbonate. Administering the phosphate binders will result in bringing up the calcium levels. It should also be given on time. Signs and symptoms of low calcium levels include numbness and tingling of the fingertips around the mouth and the tongue, which is usually the earliest symptom or sign, muscle cramps, muscle twitching, muscle spasms, bone pain, and joint pain. Chvostek sign and Truser sign is also seen in later stages. Calcium supplements are usually given to patients with CKD. Alendronate or Fosamax is usually given for bone weakness and osteoporosis in CKD. Side effects include acid reflux, gastritis, and nausea, and therefore one must not lie down for 30 minutes after swallowing this pill with a full glass of water. This will help avoid damage to the esophagus, and the water will wash the medication down to the stomach. Therapeutic management. A diet low in protein, usually 60 grams, restricted fluids depending on whether the patient is on dialysis or not, salt substitutes that usually contain potassium are avoided, and so flavor enhancers like lemon juice, spices, and herbs are used instead. Electrolyte replacement or restriction, usually 2 gram sodium, 2 gram potassium, and calcium supplements are given. Sodium bicarbonate tablets to treat acidosis. Monitor and plan nursing care for hyperkalemia, hypertension, and congestive heart failure. Prepare patient for dialysis or renal transplant as indicated. Strict eyes and nose and vital signs, monitor lab results, mainly BUN, creatinine, CBC, electrolytes, and pH. Provide symptomatic relief for nausea and vomiting. Provide rest periods to combat chronic fatigue. Help patient to learn about the disease process to better understand the need for restrictions, prevent complications, and understand prognosis. Support coping strategies and work with patient to develop realistic goals. Monitor and treat for infections promptly. Medications include diuretics, antiemetics, antihypertensives, phosphate binders, folic acid, multivitamin, iron, and erythropoietin. Client teaching. This includes monitoring the weight and vital signs and urine output at home, fluid and dietary restrictions, including low sodium, potassium, phosphorus, and protein. This needs to be followed carefully with the help of a dietitian. Monitors symptoms of uremia. Avoid nephrotoxic drugs like NSAIDs, contrast agents, metals. Cautious use of over-the-counter drugs. Teach strategies to avoid thirst, such as frequent mouth care, sugarless candy, using ice chips, using a spray bottle instead of a cup to limit the fluids ingested. Discuss hemodialysis or peritoneal dialysis or renal transplant as indicated. Recommend methods to combat nausea, which includes mouth care and small frequent feeds. Provide referral to mental health counseling or support group as necessary.